So thanks to the organizers for having us talk a little bit about autopsy findings. My comments are going to be based on the first 24 autopsies, including 17 men and 7 women from ages 38 to 93 years. We study them fairly extensively with many transmural sections from both ventricles and the interventricular septum and the coronary arteries. So we're getting a good look at the myocardium. One case has lymphocytic myocarditis. This has been reported by a few other centers. It looks like a typical viral myocarditis, predominantly lymphocytic. You can see all the inflammatory cells, the small round blue nuclei here. The arrows are pointing to small foci of myocyte damage, and this might account for some of the troponin leak that has been identified as a sign of cardiac injury, and there are also EKG changes, again suggesting some cardiac injury. So we have seen this myocarditis in just a single patient. We did also see a very interesting myocyte, cardiac myocyte degeneration in a patient who also had obvious acute myocardial infarcts elsewhere in the heart. However, on this Masson trichrome stain, you can see normal muscle on the right and the left, stains in this reddish color, and they are still nuclei, blue nuclei present in the cells. But in the middle here, there's a whole area of myocyte degeneration. They stain differently, this sort of bluish gray appearance, and they have big vacuoles. So this is a form of myocyte damage. It is, however, not obviously ischemic in origin. It does not look like coagulative necrosis, and also interestingly, there is no inflammation. An acute myocardial infarct should have neutrophils coming in. So the thought that the virus may be inducing apoptosis, which would be without concomitant acute inflammation, is a very interesting concept. Here we see again some additional myocyte degeneration, normal myocytes at the top and bottom with their nuclei present, but in the middle here, damage to myocytes, their cytoplasm all clumping together and their nuclei are lost, and there's a little pigment here, probably leftover lipofuscin from a myocyte. So again, there is very focal myocyte damage. These will be leaking troponins, but interestingly, there is no inflammation associated with it. There have been reports of particularly right-sided failure. We have seen interstitial edema. So between the red myocytes here is this rather amorphous blue-gray appearance of the tissue which is separating myocytes. So this is in fact interstitial edema, which physiologically would tend to make the heart stiff. There's another change we have seen, some myocyte degeneration, interstitial edema, this blue-gray material around a small vessel here, and myocytes have these unusual vacuoles in them. It's not obvious coagulative necrosis, but it raises the possibility, could this be ischemic injury just from vasoconstriction or from poor pumping by the heart? We have seen, of course, a fair amount of cardiac comorbidities, including coronary artery atherosclerosis, some associated acute myocardial infarcts. Many cases have myocyte hypertrophy and interstitial fibrosis, very non-specific changes, which could be related to systemic hypertension. And 2 of the patients, the more mature patients, did have some what appears to be senile cardiac amyloidosis, which probably did not contribute to their disease. Interestingly, we have not seen microthrombi, as Dr. Saki has seen in the lung, and we've also not seen vasculitis. And when the thought that smooth muscle cells have ACE2, you would think there might be an attack on vascular smooth muscle. We have not seen that. And certainly it is possible that changes in endothelial function have played a major role in the pathophysiology of the disease. So I will stop there.